So, 48-year-old female with no known cardiac history. She presented to outside hospital ED September 15th with acute worsening chest pain and also like 3-month history of worsening chest pain on exertion. Past medical history, nothing cardiac. Surgical history, just knee replacement, hysterectomy for abnormal uterine bleeding. Family history of hypertension, CAD in the mom side. She denied smoking, but she admitted to smoke marijuana every day. And meds, just anti-anxiety, no allergies. So her, like, just a quick summary, like how her symptoms evolved. She really described like discomfort in chest for about 3 months duration, substernal, some mixed kind of typical and atypical symptoms. Then in August, she presented to outside hospital ED with a chest pain, 10 out of 10, sweating, nausea. Troponins were negative, EKG, no acute changes. She was labeled with anxiety, discharged on Xanax. She went to Jamaica for a vacation, September, and there she had also some atypical symptoms of cough, URI symptoms, also acute chest pain. So she eventually presented like on the 15th September with chest pain after going to urinate. She felt acute chest pain with diaphoresis, dyspnea on exertion, nausea, vomiting, more typical symptoms. Obviously, like any patient going through the ED, she got CT-APE study that was negative. This time, if you just look like, is it like, okay, so basically in August, she had negative troponin. Upon presentation, she had troponin of 0.08, and this time really peaked into like to 1, which is really concerning. This is the EKG in August. This is the EKG this time, which is really more concerning with, kind of well on kind of sign. On the EKG physical exam, nothing remarkable. She had chest wall tenderness for whatever that was. Okay, so the angiogram. Like, just quick question here, like, anybody concerned about anything in this images? Kind of ectatic looking, proximal LAD, even the left main, and weird takeoff of the LAD. Obviously the cranial view, you see the LAD here, kind of ectatic. And in this view is like really diving down and then up in this RAO caudal. So just like any, if you're really concerned about the clinical scenario, just like any other case, you take more views. And in this view, which is RAO caudal, but more kind of maybe steep RAO, there is this ostial lesion, or whatever it is, something is suspicious in the ostial LAD. With this history, this is the RCA, and the LV gram here, LAD distribution, wall motion, abnormality. So I think it's not unreasonable to have like SCAD in differential diagnosis. And the operator at that time felt, she is hemodynamically stable, you have timid flow in the LAD, ostial LAD. If it is a SCAD, if you try to intervene, you might just make things worse all of a sudden. So the plan was to send her to our center, cardiac ICU, and really kind of discuss the options. If you're concerned about SCAD, I'm not sure if anyone concerned about anything else at this point. Kind of, conservative management, maybe watch her, see how she does, the PET cath or imaging, the CT, You don't want to rush her to the cath lab, but probably you consider like cardiac, surgery just to see the patient in case she become unstable. She was hairplanized, monitored, and as we discussed. So she was having more chest pain just because of, to cover, a kind of heart team approach, we called CT surgery, and she was very, very upset. She said no. She kind of kicked him out of the room. She doesn't want to consider any options of open heart surgery. But she had, it was a weekend. We kind of were trying to put off things like, let's just wait, see how you do because, the concern of SCAD. But she had worsening chest pain. On the Sunday, we just kind of looked at the CTPE that she had. There was like unusual, obviously this is not, optimized to evaluate coronaries, the contrast NDPA, but you can see Like there's calcification in the osteo-LAD. There's nowhere else, any calcium anywhere else. Okay, so we repeated cath on a Sunday, looking the same. I mean, obviously, you would like to get more data, and I think everybody would agree you would try to maybe image it. Maybe consider FFR if you want to intervene. Anyway, for the sake of time, very difficult to wire. Angulation, severe lesion, you cannot really open up in any good view. We use superclass, and with difficulty we were able to wire it. We did FFR just to kind of complete the evaluation, and very ischemic. And we did OCT. And the OCT, you can see it's like really big vessel. Don't worry about this, this is just artifact from a huge vessel. Kind of, you see how the OCT is kind of biased into the other wall here. So there is no evidence of atherosclerosis. Here's the transition from the LAD to the left main. I will repeat that because that's the key here. So again, the things that we were looking for, no atherosclerosis. So we're not dealing here like with a athero lesion. There is this transition from the LAD into the left main. Very unusual. Again, no athero, it just looked like a kink or a twisted artery. This is not a great image. This is 3D reconstruction of OCT, but because of the artifact and the, all of these things, but you can appreciate how the LAD here and the left main, and this is like kind of twisted and kinked. Then obviously the next question is how do you deal with this? We obviously already kicked out the CT surgeon from the room, from her room, she did. So there's no option of surgery. Obviously PCI, we went with a larger stent. The actual left main was like 10 millimeter probably, LAD approximately, also probably 7, 8, a huge vessel. You can see how the wire is biased from like this wall in the left main to that wall of the other wall of the LAD because of the whole anatomy is strange. Went with a larger stent, 5 by 12, and we just deployed it. And we did another OCT. It's just the final results here. Okay, kind of straighten the segment. Obviously, I think everybody wants to know how the OCT looked like after this, and this might spark like a lot of questions. We're happy to discuss it really quickly, but for the sake of time, I'll just scroll here, show you. You can see the stent. I admit the stent is floating in the LAD, but again, it's like about 8 millimeter or even more vessel here. And this is the kind of the segment that we kind of straightened with the stent, and it's floating also in the left main. We did not post-dilate. I think we can open that to discussion quickly, but we did not post-dilate. I think for this, the whole idea here is to support that segment. We're not dealing with atherosclerosis, we're not dealing with a lumen area. This is like the left main was 32 millimeters square, similar to the LAD, so we're not worried about stent thrombosis. And you don't want to deform the stent, because then you lose the whole idea of supporting that segment, the kinked or twisted artery. Okay, I think I already showed you this, but before and after, and thank you all for the attention.
Very good. I had one case just like this on a young patient, 30-year-old, and she had a scleroderma crest syndrome. And I think that, totally clean arteries, no atherosclerosis anywhere else, but just focal.
Just like focal,
okay. And we ended up sending it just like you did. I think it's an open question whether you should post-dilate this one with a peripheral balloon. I think that's a reasonable question here, given the size of these vessels. But
you'll probably never get apposition from what he's describing, so you might mangle the stent. One thought is to use a renal stent, Herculink or something that you can take bigger.
I think that anyway, I think it's very risky. I think that if you dissect proximal or distally, you're in big trouble, and that the patient may go into a path of no return, because it's almost immediate shock if you even either dissect distally or proximally. Sometimes the implant can be like tissue paper, especially in a young female. She's 40.
She's 42, 48.
42.
Yeah, in the 40s.
So I would think about non-atherosclerotic.
Yeah.
Even though she had calcium,
So that calcium, I think she had like long-standing issue in that segment. Inflammation from a kink, that progressed over time and then acutely worsened. So there was like some focal, abnormality there for a long time. That's why she had calcium there, but it was not atherosclerosis.
A mid-cap or something that is less invasive and secures. I mean, that's definitely significant. So the only problem is that there's so much inflammation that this may open up in the future. If you put a graft, the graft may not work, but at least to get you out of the problem. But it's interesting. It's an interesting approach.
Fortunately, we know that stent expansion is adequate, and so you don't need as much apposition. It's
Exactly.
stent expansion that's the risk
Exactly.
for stent thrombosis. So I think you did the right thing leaving it alone. Let's move on to the next.
One comment, as big as this artery is, it's like an SFA in the heart. And so basically, there is so much twist that, people have used self-expanding stents. And, that could be one option to actually put in a self-expanding stent. You get, a much bigger lumen. You can post-dilate it. You probably have less risk of dissection, perforation at the edges. Exactly, a carotid stent, I've not used it in the Alaiti, I've used it a couple times in the RCAs, but I mean, that might be another option, just because the way it is, it's,
Yeah, that's
now it's.
Great point, and that's why you guys are all dual trained in vertical. It's wonderful.
Hi, very nice presentation. So the presentation of this patient was ACS, was it?
Yes, the last one she presented with was ACS.
The reason that you put in a stent was ACS?
I mean, yeah, because she had like this time NSTEMI, it's a 0.1, LV wall motion abnormality, like EKG changes, everything was consistent with, and FFR was 0.5. Yeah, we did FFR, yeah, it was 0.5. We were trying to do everything that avoid doing anything, intervention, but we couldn't.
All right, we're going to move on to Dr. Thank you very much.
Thank you.